I am the next presenter, so you all know me now. So I'm going to share my screen. Let's see here. Okay. So thank you again for the meeting, for the opportunity to share with you our research. Is not the results I would like to show you, but we had to stop some of the trials because of COVID situation. So I'm going to show you some interesting results about using modulated electro-hyperthermia as monotherapy for treating painful bone metastases. That maybe can be a new or almost new promising indication, although I know some of you already use this. We know that bone is the most frequent site of metastases in most of the common cancers, and we also know that it has very bad consequences for patients. They suffer a lot, they have a lot of impediment on their quality of life and expectancy, so it's something really, really important. We know that some of the main treatments for painful bone metastases are, of course, analgesic. We usually use opioids at high dose, and that is a problem because they have very important side effects, which are really negative for patient quality of life. We can also use biphosphonates, we can use calcitonin. Of course, we can use systemic treatment with chemotherapy, immunotherapy, but the problem with these treatments is that they are usually slow, so the patient suffers a lot until they have a good response, and very frequently they are not enough for controlling bone pain metastases. Of course, we have radiotherapy. Radiotherapy is very effective on controlling pain from bone metastases, but we have important limitations. One of them is the dose limitation, because we have the organs at risk which cannot stand very high doses of radiotherapy. And the other limitation is that we know that we treat radiotherapy and it's very hormone, but we usually need to treat again the patient maybe 6 months later, and this is really difficult with radiotherapy because of the dose. We have another treatments, more aggressive, more invasive, like radiofrequency. We know that leaf tissue is heated beyond 57 or 60 degrees. We have coagulation, necrosis, and we can kill cells. We know that. But one important problem is that this heating is not selective, and it can have a lot of side effects that sometimes are really, really bad. So we have to be very careful with this type of treatment, because we have seen like very bad reactions to that. So regarding hyperthermia, you all know hyperthermia. You know that we have several studies about painful bone metastases treated with hyperthermia, but mainly are combined with radiotherapy. So in these trials, we have the good side, that is combining hyperthermia and radiotherapy is usually more effective than radiotherapy alone. And this is very interesting, because maybe we can also decrease dose from radiation, and that way we can treat like twice instead of once with radiotherapy. So it's really interesting. But we have also the bad side from the radiotherapy limitations, because we have the limitation of the dose. Sometimes we also have the limitation that we don't have the hyperthermia unit and the radiotherapy unit very close, and this is also difficult. So if we think about treating with hyperthermia alone, Professor Lee in the presentation was talking about this, using hyperthermia for pain, for example. And there is almost nothing published about this, no trials. We have comments in different studies. This is, for example, a report that was presented in 2012 in the ICHS meeting. And you see that it says that it is possible to apply Oncothermia to reduce metastatic bone pain with a variety of cancers, but we don't have like a trial, a specific study for this. So we know that there are important molecular players in cancer-induced bone pain. We have more oxygen in the bone marrow than in the bone. So when we have tumoral cells in the bone in that low oxygen pressure, we have some problems because the microenvironment of the tumor changed from being like more oxidative to more glycolytic. It creates protons, and those protons are going to stimulate nociceptive neuron terminals, which are going to give the patient the feeling of pain. So this is an important problem for them, because we know that bone pain is a very bad pain. So we also know that hyperthermia increases blood perfusion. It also increases oxygen levels, so it decreases hypoxic areas. So we can think that if we hit those bones with bone metastases, we can create a vasodilatation inside the tumor, we can decrease hypoxia, and this way we can decrease those protons release and those nociceptive stimulus. So this can be really, really interesting. So what we did is some months ago, we prospectively began including patients. We have included now 12 patients. I have here the results from 10 of them. They had different types of primary tumors. They also had, of course, painful bone metastases. And we tested a modulated electro-hyperthermia as an analgesic treatment for these patients. All patients had pain which was not responding to systemic or analgesic treatment, so there were no new treatments besides modulated electro-hyperthermia for bone pain relief. They were all under high dose of opioids and other analgesics with a lot of side effects because of this. And all treatments at painful bone metastasis sites were prescribed for pain relief as main objective, not for tumor control. So these are the 10 patients. You see that most of them were females. 9 of the patients had solid tumors. You see breast, UIN, lung, sarcoma. And one of the patients had a multiple myeloma, who had only one vertebral body affected. Of course, all of them were stage 4, and the patient with myeloma had a stage 3 ICHS. 7 patients were under systemic treatment, but they were not improving regarding pain with that treatment. You can see here what patients were under that treatment. 3 of the patients were unable to walk because of pain. The myeloma, the sarcoma, and the breast case were unable to walk. One of them was able to walk, but with help. And the other 6 were able to move but by their own, but they were limited, very limited by pain. 4 patients also received treatment with modulated electro-hyperthermia at other no-bone sites, at their primary sites or other metastatic sites. So you see that 3 of the cases had a primary from breast cancer and another one was from cervical cancer. 5 patients have bone metastases at the column, a vertebra, and 1 patient had metastases at the femur, 3 patients at the hip, and 1 patient had ribs metastases. All patients receive between 5 and 12 treatments. This depends if they were being treated in another location because they were going to come more times or not. 80% of the patients had significant pain response to hyperthermia treatment. This was really, really good. And what is very, very interesting, because maybe this helps us to know if the patient is going to respond or not to the treatment and to avoid maybe treating them for a long time without knowing what's going to happen, is that all patients had very good response at the first treatment. They felt that improvement. This was really, really interesting because sometimes they came in a wheelchair and they go out walking, and that was like amazing. So really interesting. 3 of the patients had radiotherapy already scheduled before hyperthermia, and after hyperthermia they didn't need to receive radiotherapy, which is also very interesting. These 3 patients were the 3 ones that could not walk, so they were the worst one. And the 4 patients who were treated with hyperthermia at other no-bone sites, they have a different response. You can see that the case who was treated also at cervix with hyperthermia had a progression at that site. And at bone side, she had a very good response regarding pain. Another case from breast cancer had a good response at breast and also at the vertebra, which was treated. Another patient with breast cancer also was treated for liver metastases with hyperthermia. She had progression at liver, and on the other hand, she had a significant pain response with hyperthermia at hip mets. And the 4th patient had breast cancer, brain metastases, and she had progression at brain, but she also had a bad response to hyperthermia at vertebral mets. So I think that what is important in this information is that despite tumor progression at other sites treated with hyperthermia, hyperthermia was very effective on pain control for at least 2 of these 4 patients. So I should say that these patients had a very advanced disease, so they were not easy cases, but at least we were not able to control many times the tumor, but we were able to alleviate the pain, which was very important for the patient. It's very interesting the case with the myeloma, because we usually say that hyperthermia, especially modulated electro-hyperthermia, is for solid tumors, and this is an hematological tumor, and the response was really, really good. It was a male, 59-year-old. He was diagnosed because he had an important pain in his L4 vertebra. He had a fracture there, and he had light hypercalcemia. He had an important pain despite opioids and corticoids. His BAS scale was 9 with movement, 3 relaxed, and he could not stand on his own before treatment. He was scheduled for bone marrow transplantation after chemotherapy induction, and he was proposed for vertebroplasty plus radiotherapy before beginning chemotherapy, because the pain was very, very high. So this case was presented at Valdecilla Hospital, and we suggested to try with modulated electro-hyperthermia and see that maybe that could help and we could avoid the vertebroplasty and radiotherapy. So we prescribed only 6 hyperthermia treatments for the patient every other day. After first treatment, the patient was able to stand on his own. He was like surprised because of that. After 3 treatments, he decreased the analgesics to 50%, and he was able to work with crutches. And after 5 treatments, he stops opioids and he decreased corticoids 75%. 1 week after 6 treatment, he saw me in the hospital and began shouting because he said, okay, I am without analgesic nor corticoids, and he was able to walk on his own and climbing stairs. It was really amazing. Every time he sees me, he says, I want to be on TV telling this because this is amazing. So it's a really interesting case. He was treated on February 2020. And up to date, he already received a bone marrow transplantation, and he has not evidence of disease, and he doesn't have any pain. So I think this information is too small. We are speaking only about 10 patients, but I think we have very interesting information to go on with research at this level. Why? Because we don't know which is the pattern related to the bone pain response. Maybe it's histology. It seems like bad histologies like sarcoma, for example, had good response. So it's not only related that breast maybe is better than sarcoma. Maybe it is the type of bone, because we know that bone marrow is not the same in the hip like in the vertebral, in the ribs. So of course we don't have enough patients to raise conclusions. So I think it's interesting. We should go on investigation. It's important to know also this, which is the length of response, because we know that with radiotherapy, for example, is very frequent that we have to treat the patient a second time, and then 6 months later we need again more treatment, but we cannot do it because of radiation limits. So regarding follow-up, one patient, the patient with the cervical cancer, she had very, very advanced disease, and she died 1 month after treatment. She didn't have pain at the femur, but we don't have a longer follow-up. And all the other 7 patients who had a good response, 4 patients who have 6 months follow-up and they are still okay. 3 patients have a follow-up of 9 months and are still doing okay with some analgesic but not opioids. And 2 patients, we have a follow-up of 12 months and they are very, very, very well. It's interesting that we have a breast case with hip metastases, and the right hip was treated with hyperthermia, the left hip with radiotherapy, and the left hip is creating pain now, and the hip treated with hyperthermia is very well. So this is also interesting. So as conclusions, we see that more modulated electro-hyperthermia can be a very safe and effective treatment for painful bone metastases as a combined treatment, but also, and this is very important from my point of view, in monotherapy. Contrary to the common belief that maybe electromodulated hyperthermia does not work in hematological tumors, maybe it can have a very important role. Myeloma, we know that patients suffer a lot from bone pain. So we are now going to begin very soon a trial about this patient with this disease. And I think these findings open a very interesting path of research. So we need more studies to know indications, number of sessions, length of response, doses of hyperthermia power, these sort of things. So thank you for being here today again. And you can see there a picture from Santander where we will have the next year meeting. And of course, I will be very happy to see you there. So thank you. And now if you have some question, I am going to sorry, yeah, this is Professor Sass again. I'm going to open the chat box. Let's see. Okay. I have one question from Pyrus.
Ah, okay. May I? Pyrus, okay.
Yeah.
Please.
Yeah, hi, Pyrus Gajar from Charité. Again, thank you for the very interesting presentation and congratulations to the data. I think it's very important. I have a question regarding the selection of patients. Were they pre-treated at the painful bony site with radiation that you were concerned about organs at risk? And is it, from your perspective, important that patients have soft tissue involvement to make the hyperthermia work? And the next question is, do you think that maintenance therapy with hyperthermia is a good idea when it's so effective? Why should one stop then the treatment? Thank you very much.
Thank you. Yeah, here the patients, most of them were patients who came in order to ask for hyperthermia for the pathology, or because they know that maybe this could help with the tumor. So the important thing is that all of them were treated at both sites because of pain, not because of a tumor control, because you know they have a lot of metastases, maybe in the wrist, in the hip, in the scapula, and we cannot treat everything, but we were just treating the part of the body that where they have a lot of pain. In these 10 patients, only one had soft tissue involvement. It was a patient who was inside the hospital with treatment, endovenous treatment, because it was being very difficult controlling the pain, and she had a lot of improvement. In that case, the patient finally died months after the treatment, but we had to treat the patient like every other day for a long time, because otherwise we lose like the effects of the hyperthermia. So we see different things. Some patients like need a lot of treatments to have that pain control over the time. And some patients maybe with 6 treatments are okay. So it's difficult to know why, but what is very interesting is that you can see the improvement at the moment. We began this study because we were treating patients, for example, for liver metastases, and when they got up from the bed, they say, okay, my back is much better now, and they have like vertebral metastases, and say, okay, interesting. And then we try. So let's, for example, a patient came to be treated for liver, and he had pain in the hip because of bone metastases, and we say, okay, let's try to treat this. And it was, the response was very good. So we thought, okay, this seems like very, very interesting. So I think it may be a treatment that we can repeat over the time, because you know that these patients are usually palliative cases, and you can use radiotherapy once or two, but you cannot use more radiotherapy. So you have a new tool to use that it would work, because we see very, very interesting results. And my experience is that in those patients, if the treatment works in the first treatment, it will work. If in the first treatment the patient feels like nothing, it will not work. But it's very frequently that it works. They improve regarding pain. So I think it's interesting.
Thank you.
Thank you. And Dr. Tedros, so you are asking something, I can read your question, or you can ask it as yourself. Yeah, you were asking about if the patients were not responding to cannabis medication as painkillers. We usually don't have many patients with cannabis medications in Spain. It's not very frequent, so we usually don't see those patients. It's not a standard treatment in Spain. We don't have that treatment in the public system, and there is only like 1 or 2 centers performing that. So we don't have the experience to compare which is better or if it helps.
Hello, Elisabeth. I think I managed to unmute my microphone.
Okay.
How are you doing? I want first to congratulate you for the very interesting presentation, and secondly, for this excellent organization under difficult conditions. I was raising this question because I have the impression that in Spain, cannabis treatment as a palliative is very extensive. because the legislation is suitable for that. I'm very interested in cannabis because I see, based on biochemical data, that it induces apoptosis in several manners that could possibly act in concert with oncothermia. So this is very interesting for me, and I use cannabis in my patients very frequently. And also it matches our own observation that oncothermia as monotherapy acts very well and very fast on the pain on metastasis. I think in the beginning it was very curious observation, but probably it is so fast because it reverses instantly the local biochemical modulators of pain within the bone, which is of course reversible, and it has to be repeated and repeated and repeated over and over again until the neoplasm is kept under control. Thank you very much.
Thank you. Thanks for your comment. I think we are a little bit late. Sorry, because as I was speaking, I was not checking times. So sorry for that. And I think that later, if you want, you can send me email or anything, but we should move forward with